In this video, we're diving deep into a rare and complex inherited disorder, primary hyperoxaluria, or PH. We'll explore what it is, what causes it, and how it's managed. Let's get started. So, what causes this condition? Primary hyperoxaluria is an autosomal recessive genetic disorder. This means that a person must inherit 2 copies of a mutated gene, one from each parent, to develop the condition. These genes contain instructions for specific liver enzymes involved in oxalate production. Mutations in these genes disrupt the normal function of these enzymes, leading to an overproduction of oxalate by the liver. Now let's talk pathophysiology. Simply put, PH causes the body to make too much oxalate. Oxalate is a natural substance found in some foods, but our bodies also produce it. Normally, the kidneys filter oxalate from the blood, and it's excreted in urine. However, in people with PH, the excessive oxalate overwhelms the kidneys. This excess oxalate combines with calcium to form calcium oxalate crystals. These crystals then deposit in the kidneys and other organs, leading to kidney stones, kidney damage, and eventually kidney failure. As kidney function declines, oxalate builds up in the blood, leading to systemic oxalosis, where oxalate crystals deposit in other organs like the heart, bones, eyes, and skin. Primary hyperoxaluria is a rare disease. It's estimated to affect about 1 to 3 people per million worldwide. Because it's a genetic condition, its prevalence is relatively consistent across different geographical regions. However, certain populations may have a higher risk due to consanguinity or marriage between close relatives, which increases the likelihood of inheriting 2 copies of the mutated gene. The signs and symptoms of primary hyperoxaluria can vary depending on the type of PH and the person's age. Some individuals may experience symptoms in early childhood, while others may not develop noticeable symptoms until adulthood. Common symptoms include recurrent kidney stones, blood in the urine, and pain in the abdomen or back. In advanced stages, symptoms of kidney failure may appear, such as fatigue, swelling, nausea, and decreased urine output. Systemic oxalosis can lead to bone pain, heart problems, vision problems, and skin rashes. Diagnosing primary hyperoxaluria can be challenging due to its rarity and varied presentation. Diagnosis typically involves a combination of blood and urine tests to measure oxalate levels. Genetic testing is also crucial to confirm the specific gene mutation responsible for the condition. Imaging studies such as ultrasound, X-rays, or CT scans can help identify kidney stones and assess kidney damage. In some cases, a kidney biopsy may be performed in the extent of oxalate crystal deposition. There are 3 main types of primary hyperoxaluria, each caused by mutations in different genes. Type 1, caused by mutations in the AGXT gene, is the most common and typically the most severe. Type 2 is by mutations in the GARHPR gene, and Type 3 is by mutations in the OA1 gene. Types 2 and 3 generally have a later onset and a slower progression than Type 1. Knowing the specific type of PH is crucial for determining the most appropriate treatment strategy. The goal of treatment for primary hyperoxaluria is to reduce oxalate production and prevent oxalate crystal deposition. Treatment options include high fluid intake to flush out oxalate from the kidneys, medications like pyridoxine and vitamin 6 to reduce oxalate production in some individuals, and potassium citrate to inhibit calcium oxalate crystal formation. In advanced cases, kidney transplantation or liver kidney transplantation may be necessary. Dialysis can help remove oxalate from the blood temporarily, but it's not a long-term solution. More recently, NRA-based therapies and other novel therapeutics are becoming available to reduce oxalate production and prevent kidney damage. While there's no definitive way to prevent primary hyperoxaluria since it's a genetic condition, genetic counseling is recommended for families with a history of the disease. This can help them understand the risks of having a child with PH and explore options like prenatal testing. For individuals already diagnosed with PH, adhering to the prescribed treatment plan, including high fluid intake and medications, is essential to minimize oxalate buildup and prevent complications. The prognosis for people with primary hyperoxaluria varies depending on the type of PH, the age of diagnosis, and the effectiveness of treatment. Without treatment, PH can lead to stage renal disease and systemic oxalosis, which can significantly shorten lifespan. However, with early diagnosis and appropriate management, the progression of the disease can be slowed and the quality of life can be improved. Recent research is focused on developing new and more effective therapies, such as gene therapy and novel medications, to target the underlying genetic defects and reduce oxalate production. These advances offer hope for a better future for individuals living with primary hyperoxaluria.